Hello, everyone. My name is Alon Mazuri. I'm an assistant professor of endocrinology at Mount Sinai and one of the co-leaders of the Mount Sinai Morningside Osteoporosis program. I'm so excited to be here today to talk to you about a high-yield guide to osteoporosis care. Today's objectives are to understand the morbidity and mortality caused by osteoporotic fractures, to review the paradigm shifts in osteoporosis pharmacotherapy, and to identify the optimal medications and treatment sequences based on fracture risk. I have no disclosures. If we take a look at how bone mass evolves over the lifespan, we'll see that there are two key phases. The first is in the first 3 decades of life, in which bone formation or modeling is taking place, and peak bone mass is achieved around age 30. And then we see that in the later decades of life, there's progressive bone loss. And if we focus on that arrow indicating menopause, we'll see that women experience a particular dip in their bone mass as a result of estrogen deficiency from menopause. This information allows us to construct a definition for osteoporosis. It is a silent skeletal disorder characterized by compromised bone strength, predisposing to an increased risk of fracture. Bone strength reflects both bone density and bone quality. And as we know, bone density can be readily measured with DEXA scans. Symptoms, which could be back or thigh pain, occur only after a fracture. So if no fracture has occurred, then osteoporosis is not responsible for the symptom. If we take a look at these two scanning electron microscopy images, we see that on the left, there is a normal bone density and a patient without osteoporosis. But in an osteoporotic bone, there is much lower bone density, and this has a much higher risk of fracture. In fact, the small arrow in the bottom left-hand corner of the right-hand image indicates a microscopic fracture. Why does osteoporosis matter? Over 50% of postmenopausal women will have a hip or spine fracture, and actually over 20% of men will have the same complication. There are over $57 billion in annual fracture-related costs, and a 5 to 8-fold increased mortality after an osteoporotic hip fracture. If we take a look at the fracture rate or incidence, we see that it occurs the most in people with the lowest bone mineral density. Here in the box are people whose bone mineral density are minus 2.5 or worse. We see the gray bars indicate the fracture rate or incidence, and it is highest in osteoporosis. However, if we turn our attention to people whose bone mineral density is in the osteopenia range, between minus 1.0 and minus 2.5, we see that the black bars are the tallest. And these black bars are the number of women with fractures or fracture prevalence. And accordingly, both osteopenia and osteoporosis are important because one fracture predicts another. From this very large retrospective analysis, we see that if a patient had a clinical vertebral fracture, they have double-digit risk of a subsequent vertebral fracture within the next 24 months, specifically at 12 months, a 10.1% risk, and at 24 months, a 15.9% risk. And we see on the right-hand side that if the index fracture is a hip fracture, we see a similar trajectory in terms of increased fracture risk. If we wanted to define osteoporosis, we could use the American Association of Clinical Endocrinologists criteria, which are in line with the criteria from other national and international societies. We see one, a T-score of minus 2.5 or below in the lumbar spine, femoral neck, total proximal femur, or distal 1/3 radius. There's a low trauma spine or hip fracture, regardless of bone mineral density. A low trauma fracture is a fracture that is caused, for example, by a fall from standing height. Number 3, T-score between -1.0 and -2.5 with a fragility fracture of the proximal humerus, pelvis, or distal forearm. And then 4 is a T-score in the same range, but a high fracture risk as calculated by the FRAX calculator. This helps us understand the different screening criteria. And while I recommend following all of these different parameters for screening, particularly high-yield ones are all women over the age of 65 and all postmenopausal women that have had a fracture without major trauma, as well as individuals with these risk factors. Long-term systemic glucocorticoid therapy, even prednisone 5 milligrams for at least 3 months, family history of osteoporotic fracture, and early menopause. Age is one of the most important risk factors for a future fracture. If we see here, for people whose T-score was -3, indicating severe osteoporosis, the impact of age can be exponential, and the older the individual, the greater the risk. And so an 80-year-old whose T-score is -2.5 or -3 actually has a much higher risk of a fracture compared to an individual with the same T-score but aged 50. For causes of secondary osteoporosis, we see that there are myriad causes. I would suggest focusing on a few high-yield ones: hyperparathyroidism and hyperthyroidism, alcoholism and vitamin D deficiency, aromatase inhibitors, seen most commonly in the setting of breast cancer, anti-seizure drugs, and if nothing else, please remember glucocorticoids. And then, of course, renal insufficiency and rheumatoid arthritis. As a result, when we think about our core biochemical evaluation, we think about hyperparathyroidism, which would be diagnosed with a CMP, 25-hydroxyvitamin D, and parathyroid hormone. Hyperthyroidism, where a TSH could be sufficient, but a free T4 can be useful. CKD and hypovitaminosis D. And we appreciate that the first 5 labs essentially encompass the whole panel. If we shift gears to treatment, then this cartoon will help us. So we know that in osteoporosis, there's weak porous bone that increases fracture risk. And in anti-resorptive therapy, we stop the weakening of the bone. We stop the progression. In anabolic therapy, we actually reverse bone weakness. And you can imagine how the combination of anabolic therapy to reverse the weakening of the bones, and then anti-resorptive therapy to metaphorically lock in the stronger bone, is a very attractive option. Current guidelines recommend a risk-stratified treatment approach. As you can see here, it gets fairly complicated. Let's focus on a high-yield approach. So if the patient only has high-risk osteoporosis, which is effectively that they've never had a fracture and that their T-scores are between -2.5 and -3.0, then we'll focus on anti-resorptive therapy, which most commonly will be bisphosphonates like alendronate or zoledronate, also called zoledronic acid. Another option is denosumab, and denosumab's interesting properties merit a separate conversation that we will get to later. In terms of very high-risk osteoporosis, which is effectively the other individuals, T-scores of -3.0 or worse, multiple spine fractures, or T-score that's -2.5, but they've had the fragility or low trauma fracture. Or a T-score of -2.5 or worse, and they've had a prior fragility fracture or low trauma fracture. Medications in this category would include teriparatide, abaloparatide, romosozumab, and again, denosumab, because of its very interesting properties. Therapy sequence is key. This is one of the most important points I can make. If the patient has very high-risk osteoporosis, then we want to first start with anabolic therapy and then stabilize or lock in the gains with anti-resorptive therapy. We do not want to first start with anti-resorptive therapy and then use anabolic therapy. The reason for this is that initial bisphosphonate therapy decreases the efficacy of subsequent anabolic therapy. And so in this study, which is relatively small, but took a look at total hip bone mineral density changes, we saw that in the romosozumab group, there was 58% less benefit if the patient had been treated with a bisphosphonate prior. And this is very meaningful because romosozumab is our most potent anabolic therapy at this point in time. So now we're going to talk about the different medical options that are available to us to treat osteoporosis. Let's start first with alendronate. So in terms of its effectiveness, this is data from the fracture intervention trial, which is alendronate's claim to fame. Here we see that in individuals who had osteoporosis at the femoral neck, they had a relative risk reduction of a vertebral fracture of 50% and a number needed to treat of only 35. And this is pretty impressive. In terms of the length of the benefit, we took a look at this in the fracture intervention trial and the flex extension study. And we saw that compared to placebo, individuals who continued alendronate past 4 or 5 years experienced progressive spine bone mineral density gain. The problem is that if we take a look at the length of benefit of alendronate, we'll see that in individuals who completed about 4 years of treatment and then went on to placebo, there was preservation of the bone mineral density gains at the lumbar spine. The problem was at the hip. Individuals who stopped alendronate actually returned to baseline bone mineral density after 5 years. And so alendronate conferred a benefit arguably between 5 to 10 years. In summary, alendronate does have some key advantages. There's oral administration, a well-established safety profile, and it's the least costly. However, there are meaningful disadvantages. Compared to other pharmacotherapy, there's less fracture reduction, and studies have shown up to 50% non-adherence after 1 year of therapy. There's a shorter duration of benefit, and 5 years of treatment are needed for full benefit. Because it is a pill and it's a bisphosphonate, it can irritate the esophageal and GI mucosa. There is a creatinine clearance requirement of at least 35, and so this is not suitable for individuals with CKD. And there are very rare risks of atypical femur fracture and osteonecrosis of the jaw. We will discuss these 2 risks in more detail later. If we move on to zoledronic acid, in terms of its effectiveness, we see that there's a relative risk reduction of 77% and a number needed to treat of 48. Very impressive. And if we switch over to the data for hip fracture, we see a relative risk reduction of 41% and a number needed to treat of 91. Also impressive. Here, if we wanted to get a sense of the length of benefit of zoledronic acid, we need to use studies in individuals not in osteoporosis because the extension studies for osteoporosis did not fully answer this question. This study showed that for individuals with a t-score between -0.1 and -2.4, 1 dose of zoledronic acid preserved lumbar spine bone mineral density for up to 10 years. And in this smaller study, with individuals whose t-score was between -1.0 and -2.0, zoledronic acid given just once preserved lumbar spine bone mineral density for 10 years as well. So to summarize, zoledronic acid has more advantages. It's a once-yearly treatment schedule if given once a year for 3 years, as in the original study that showed the relative risk reduction of 77% in the lumbar spine. Arguably, there's a longer duration of benefit. There's a short treatment course with a well-established safety profile, and there's no risk of GI mucosal irritation. Side effects with the first infusion in particular could be fever or myalgia, and these can be effectively prevented with Tylenol. It is also FDA approved for primary prevention of osteoporosis. Disadvantages: this medicine is not a pill, it has to be given IV. There's about a 1% risk of a transient creatinine elevation that resolves within 1 to 2 weeks. Creatinine clearance must be over 35, and so this is not suitable for people with CKD. And again, atypical femur fracture and osteonecrosis of the jaw, risks that are common to all anti-resorptive therapy. If we move on to denosumab, we see that there are some very interesting properties. So one is that denosumab progressively builds bone mineral density at the lumbar spine and also at the hip, the distal third radius, and the femoral neck. Here, we see that after 10 years of treatment with denosumab, there is a progressive increase in the lumbar spine to almost 22%. And this is so impressive because we note that only 5% would have been statistically significant. But I would say that we do not need to wait 10 years. At just 3 years, we have a relative risk reduction of 68% and a number needed to treat of 21. However, denosumab cannot be stopped abruptly. Here we see that in individuals who are treated with denosumab for 2 years and then the medication was discontinued, lumbar spine bone mineral density rose and then went down to baseline rapidly. The story is even worse if we take a look at the total hip, where for some individuals, the bone mineral density after denosumab discontinuation fell below baseline. And so denosumab has important advantages. It's a convenient treatment schedule because it's an injection every 6 months, impressive and progressive benefits at multiple sites, not just the spine and the hip, with a well-established safety profile because we have data up to 10 years of treatment. And it's the only anti-resorptive option if the patient has CKD. However, this is potentially lifelong therapy because of the risk of discontinuation. In severe CKD, there's a risk of hypocalcemia. It can be mitigated with proper supplementation of calcium and vitamin D. And again, the risks of atypical femur fracture and osteonecrosis of the jaw. If we move on now to anabolic therapy, let's talk about teriparatide and abaloparatide together because they are quite similar. So in the trial that got teriparatide FDA approved, we noticed that if we took a look at lumbar spine fractures, there was an impressive 65% relative risk reduction in individuals who took teriparatide for 2 years in terms of multiple lumbar spine fractures. However, the study was underpowered for hip fractures. And so we can only truly comment on benefit in the spine to our patients regarding teriparatide therapy. What we also note is that because the benefit is cumulative, about 2 years of therapy are needed in order to achieve this relative risk reduction. Abaloparatide, or Tymlos, is quite similar to teriparatide. In this trial that compared placebo, teriparatide, and abaloparatide, it is unsurprising that teriparatide and abaloparatide both significantly reduced the risk of clinical fractures. However, there was no statistically significant difference between teriparatide and abaloparatide in this regard. And so when we think about these two treatment options, we note the large vertebral fracture reduction, but also no clear hip fracture reduction. Teriparatide has decades of safety, and because this is based on a different mechanism, there's no risk of atypical femur fracture or osteonecrosis of the jaw. Disadvantages include a daily injection, which can be a significant barrier for individuals with needle aversion, the fact that 2 years of treatment are needed for full benefit. These types of therapies are not recommended if the individual has had cancer in the past. There's about a 10% risk of dizziness, So I counsel patients that if they usually sleep through the night, they should take these medications at bedtime because it is hard to be dizzy if you are sleeping. And some very rare risks of hypercalcemia and hypercalciuria. And some very rare risks of hypercalcemia and hypercalciuria. Our last medication for today will be romosozumab. This medicine is quite impressive. Within 1 year of treatment, we can reduce the risk of a new vertebral fracture by 73%, with a number needed to treat of only 77. The impressive benefit is reflected in the bone mineral density gains of the lumbar spine. At the 12-month mark, we see an increase of almost 13%. And remember, 5% would have been statistically significant. Even at the 6-month mark, we see an increase of 9.7%. And so this medication works very well and very fast. If we combine romosozumab with denosumab, we see progressive benefit. And so this reflects one of the best combinations that we have of initial anabolic therapy and subsequent anti-resorptive therapy. This combination has a relative risk reduction of 75% and a number needed to treat of 53. So to summarize, romosozumab has important advantages: large vertebral fracture reduction. I did not show this data, but there are impressive hip bone mineral density gains that rival the degree of remarkability at the lumbar spine. These bone mineral density gains are rapid, and it is a short treatment course. However, there can be injection site reactions, atypical femur fracture and osteonecrosis of the jaw. This is the anabolic therapy that actually also has these two risks. And there's a black box warning of cardiac ischemia and stroke. And this deserves some conversation. If we took a look at the trial that compared romosozumab to alendronate, this is the trial that showed differences in postmenopausal women in terms of cardiac ischemia, 0.8% for romosozumab versus 0.3% for alendronate, and cerebrovascular event, 0.8% for romosozumab and 0.3% for alendronate. If we take a look at the placebo-controlled trial, we see that there was no statistically significant difference in adjudicated serious cardiovascular events, death, or adjudicated cardiovascular death. So at this point, there is uncertainty regarding whether romosozumab increases the risk of heart attack or stroke. And so in my conversations with patients, I always ask them additional questions, such as a family history of heart attack or stroke, so I can better understand whether this potential risk may be relevant to them. Let's talk about osteonecrosis of the jaw. This is defined as unhealed exposed bone that is identified by a healthcare professional. It is extremely rare. The risk is between 1 in 10,000 and 1 in 100,000. We are worried in the setting of specific procedures, usually extractions and implants, and the risk can be mitigated by dental hygiene, smoking cessation, and drug holidays. We will talk about what a drug holiday means in the context of osteoporosis later on. In 2011, the American Dental Association issued an executive summary stating that the benefit provided by anti-resorptive therapy outweighs the low risk of developing osteonecrosis of the jaw. And in terms of comparative risks, we can appreciate that the risk of developing osteonecrosis of the jaw is actually similar to dying because of a lightning strike in New Mexico. All jokes aside, we take a look that there's an absolute risk of 0.7 per 100,000 people per year. And so the risk of osteonecrosis of the jaw is very low. If we talk about the other very rare risk, atypical femur fracture. This is a fracture located along the femoral diaphysis between the lesser trochanter and supracondylar flare. What I tell patients is that they might have a broken bone in the middle of their leg bone. Bisphosphonates increase the risk to still below 1%, and this risk can be mitigated with drug holidays. And so for every 100 fractures that would occur in people who were not treated with osteoporosis medication, only 50 fractures would occur if those individuals had been treated with alendronate, for example. And the combined risk of osteonecrosis of the jaw and atypical femur fracture is very low, less than 1%. We should talk about drug holidays, and specifically drug holidays for bisphosphonates, not the other medications we have discussed. Bisphosphonate discontinuation is recommended after a certain period of time because of a limited incremental benefit in terms of fracture risk reduction, and because there's progressive risk of atypical femur fracture and osteonecrosis of the jaw. It's recommended that we stop therapy with alendronate after 5 years, and we consider stopping therapy for zoledronic acid at 3 years. And this is because of the trial data. We see that after about 4 to 5 years of alendronate therapy, there is no incremental benefit. And for this trial, which is one of the extension studies for zoledronic acid, we see that after 3 years of zoledronic acid treatment, there is very small incremental benefit for another 3 years of therapy. How do we take all of this information and operationalize it in the context of a visit? So I would recommend a practical approach that starts with the basics. Let's take a look if the history is significant for prior fractures, history of MI or stroke, steroids, and get a sense of the patient's dental care. We should assess lifestyle in terms of calcium and vitamin D supplementation and resistance training. Get a look at the basic labs, CMP, PTH, 25-hydroxy vitamin D, TSH and free T4 to take a look at hyperthyroidism. Assess the degree of renal impairment, because if the creatinine clearance is below 35, our only anti-resorptive option is denosumab. Let's take a look at the bone density scan. Does the patient have very high risk or, quote, severe osteoporosis based off things like a T-score of minus 3.0? Or is it just high risk or just, quote, standard osteoporosis? And if we start with fracture risk, we see that if the patient is high risk, we'll consider initial anti-resorptive therapy, which includes zoledronic acid, alendronate, and denosumab. And for the reasons I discussed earlier, many patients of mine elect for zoledronic acid or zoledronate. If there is very high risk, we will consider these 3 medications: romosozumab, teriparatide, baloparatide, and denosumab. Denosumab appears in both categories because of its very interesting properties that we discussed earlier. And if there is initial treatment with anabolic therapy, with romosozumab, teriparatide, or abaloparatide, it is crucial to consolidate those gains with subsequent anti-resorptive therapy. And so to summarize, osteoporosis is a common, costly, and critical problem. Nearly 50% of postmenopausal women will have an osteoporotic fracture that increases mortality. We have an expansive pharmacological arsenal that can achieve long-lasting fracture reduction by over 70%. The fracture risk of the individual patient determines whether treatment consists of only anti-resorptive therapy or anabolic therapy and then anti-resorptive therapy. Therapy sequence is key. We start with an anabolic agent if there is very high risk. And the very rare risks of atypical femur fracture and osteonecrosis of the jaw are mitigated by drug holidays and dental optimization. Let's use a sample case to put all of this together. A 72-year-old woman with no past medical history presents for recently diagnosed osteoporosis. She has had 2 silent vertebral compression fractures. She has never smoked or consumed alcohol. Her CMP, 25-hydroxyvitamin D, PTH, and thyroid function tests are normal. 24-hour urine studies are normal. DEXA discloses a lumbar spine T-score of -3.2, right total hip T-score of -2.8, and a right femoral neck T-score of -3.0. She understands the benefits and risks of all treatment options and would like the most effective option, regardless of treatment duration. Which recommendation would be most effective? Alendronate weekly for 5 years, zoledronic acid yearly for 3 years, initial teriparatide for 2 years, followed by 3 years of zoledronic acid, or monthly romosozumab for 1 year, and then indefinite denosumab every 6 months. Now that we've had a chance to think, I would argue that the answer is the combination of romosozumab first and then denosumab later, because we see that romosozumab achieves rapid gains in this individual with very high-risk osteoporosis based off the presence of multiple vertebral compression fractures and T-scores of -3.0 and worse. And we see that the combination of the romosozumab and the denosumab achieves progressive gains at the lumbar spine, and similar data show impressive gains at the hip as well. Thank you very much for your time today.